All right, good morning, Bio 202 students. Hope you're all having a good week. Hope you enjoyed your Tuesday yesterday. For this focus session, I'm just going to go over very quickly on the cardiovascular system. I know we just started it, so it's not going to be overly crazy or in depth, but hopefully this will just give you an introduction to what we're talking about and what we're going to cover for this module. First things, congratulations again on your endocrine system exam. It went very well. This is one of the best scores I have seen in any Bio 202 class. So great job. Whatever you are doing to prepare for your exams, I would say keep doing it. Um, if you are uh, not satisfied with your exam or you're trying to do something better, then feel free to reach out to myself or Dr. Curley just to give you some different tips. But from what I could see, at least most of y'all have a very good understanding of the endocrine system and at least figured out a way to get the information, to learn it, and then apply it in the exam. So keep it up. Um, I'm not going to go through announcements. We kind of already went over that. I will talk about the flow of blood through the heart, cardiac cycle, and the keyword. Again, it's going to be very quick. I'm going to try to keep this under 30 minutes. Most of mine have been going over 30, so I'm going to try to streamline that for you guys. First one. So yesterday we went over the blood flow through the heart in lecture. Hopefully that was either very good, where you are able to clearly identify the valves, the chambers, and the blood vessels that the blood goes through. Or if you struggled with it yesterday, then it's a good indicator that you still need to practice this one. Um, again, we just started, so I'm not overly worried about it right now, but we have already gone through the major parts of the heart a couple weeks ago in lab. So for lecture, it's more of putting it all together and making sure you know how to get blood to go where it needs to go. So ideally, you can do this in less than a minute or 30 seconds. But if you look at it, the flow, we should be able to start anywhere in the heart and make it back to where you started. So I'll use the right atria, for example. So I'll say I'm starting in the right atria. Blood will flow through the tricuspid valve into the right ventricle. From the right ventricle, I go through the pulmonary semilunar valves into the pulmonary trunk, through the left or right pulmonary arteries, up to the lungs, then back through the left or right pulmonary veins into the left atrium, through the bicuspid valve into the left ventricle, up the aortic semilunar valve, then up the ascending aorta, through the aortic arch, down to the descending aorta, through the body, coming back into the heart through the inferior or superior vena cava, and back into the right atria. That was, very quick. I think it took me only about 30 seconds, less than a minute. But I was able to cover every valve, every chamber, and every blood vessel in the heart. So practice that for yourselves. Try it in different locations. This will be a question on your exam, both lecture and there will be a lab question on this as well. So I guarantee you're going to be asked something about blood flow through the heart. Just practice and know where you are. Okay, so the big one that we kind of covered towards the end of the lecture is the cardiac cycle. So depending on what resource you use, you might see different images or different text showing that there's 3 stages, 4 stages, 6 stages of the cycle. It all covers the same thing. It just depends on how people decide to break it up. But it is a cycle. So wherever you start, it shouldn't really matter because you're going to loop all the way around and then you're going to end up back where you started. So for me, second, for me to make it easier, I like to start in atrial systole, um, and then finish with ventricular diastole. So systole is contraction, probably the easiest way to remember it, and diastole is relaxation. So in this case, contraction of either the atrias or the ventricles, and then relaxation of the atrias or the ventricles. So starting from the top, atrial systole, the atrias, so I'm talking both the left and right atria, will start contracting. This will cause the ventricles to start filling with blood, and it'll force the atrioventricular valves or AV valves to open up, and those are the bicuspid and tricuspid valve. That's it. 3 steps for atrial systole. So as you contract the atrias, blood's going to go into the ventricles, and the valves that separate the atria and the ventricles will open up. In step 2, atrial systole will end and atrial diastole will start. So in this step, the atrias are fully compressed or contracted, which means they have pushed as much blood as they're going to push into the ventricles. So at this case, like I mentioned, the ventricles have what's called the max volume, or the official term is the end diastolic volume, or EDV. And this is a term you're going to need to know for lecture and for lab. So now that your ventricles are full and the atrias are in the diastole phase and they're starting to relax, the pressure in the ventricles will force the AV valves to close. And then that's it. So that'll finish step 2 here. In step 3, ventricular systole will start. So at this point, the ventricles will start contracting, but they haven't reached a pressure yet to where the semilunar valves have opened up. So while the ventricles start contracting, all the valves, so the AV valves, the bicuspid, tricuspid, and the semilunar valves, both the pulmonary and the aortic valves, are all closed or shut, and we call this isovolumetric contraction, meaning that the ventricles are contracting, but there's no blood flow at this time. As the ventricles start contracting more and more, the pressure in the ventricles will start increasing, and eventually the pressure is going to be high enough to force the semilunar valves to open up. When this happens, blood will then be ejected into the pulmonary trunk or into the aorta, and they call this stroke volume. So how much blood exits the ventricles during systole is stroke volume. Once the ventricles are done contracting, about 40% of your blood will remain in the ventricles, and we call this end systolic volume. So end systolic volume is at the end of contraction, how much blood do I have left behind in the ventricles? Like I said, it's about 40% of your blood. So 60%, if you think 100 minus 40 is 60. So 60% of your blood actually left into the pulmonary trunk or the aorta, and about 40% got left behind. At this point, since you are done contracting the ventricles and you've also ejected, over half of the blood, pressure will start to drop in the ventricles, and this will cause the semilunar valves to close. And that's it for step 3. And the last step, which is ventricular diastole, at this point, all valves are closed, and kind of how we had it up here in step 3, where all valves are shut or all valves are closed, but you were contracting, which was isovolumetric contraction. Down here, because you're in the diastole phase, we call this isometric relaxation. I think it's isovolumetric relaxation. Give me 1 second. Yep, so I was a misspelling on my part. That is isovolumetric relaxation, which would make a little bit more sense. And so at this point, right, everything's kind of relaxed. The heart's not contracting anywhere. And so blood will passively start filling the atrias coming in from the superior, the inferior vena cavas, or the coronary sinus. And as the atrias start to fill up with pressure, the AV valves will start kind of opening up just based on the pressure. And some of the blood will start passively filling into the ventricles. So it's not a full contraction and all the blood going in, but as you add blood to the atrias, the weight or the pressure of the blood will just force the AV valves to kind of open up slightly, and some blood will start getting into the ventricles. But eventually, you're going to go back to step one, where the atrias will have enough blood to contract, and you're going to restart atrial systole, and then go through the whole process again. Excuse me. So in this one, I kind of showed you the cycle, the four, in my case, for me, it was the 4 steps of the cycle. They could break it up into 5 steps, into 6 steps, depending on where you're looking. But in general, I covered everything of how the atrias contract and relax, what happens when the ventricles contract and relax. I mentioned some keywords like end diastolic volume, isovolumetric and contraction and isovolumetric relaxation, and systolic volume, stroke volume. Those are all terms you're going to need to know for lecture and lab. So study those definitions. And then be able to discuss the cardiac cycle, kind of how I discussed it, because it will be a question on the exam as well. Not sure where or how they'll do it, but you will at least get a question or two on the cardiac cycle and the steps of the cardiac cycle. And here on the right, so you remember that the heart uses electrical signals to force the atria and the ventricles to contract. The heart is what's called autorhythmic, which means it contracts or it sends the electrical signal automatically. It's not something that you have to think about. It's not a signal that changes um, based on other conditions in the body. The heart is going to do the lub dub or contract relax at its own pace every single time. The only other thing that might happen is that it might speed itself up just to make sure that you have enough blood in the body when you need it. But for the most part, the heart regulates itself. So the way it does that is you have two nodes. You have the SA node, which is the sinoatrial valve, sinoatrial node, and the AV node, which is the atrioventricular node. So the SA node is the controlling node. So this will send a signal to the right and left atria, and kind of to get them to sync up so that they compress or they contract together at the same time. That signal also has a delay going to the atrioventricular node. So you don't want the atrias and the ventricles to contract at the exact same time. It's just not efficient, and you probably wouldn't get blood going where you need it to go. You need the atrias to contract to fill the ventricles with blood, and you need the ventricles to contract to send the blood out to the body or to the lungs. So the SA node will coordinate the atrias contracting first. The signal then gets delayed. When it gets to the AV node knows or reads that, okay, the atrias are going to contract. I have X amount of seconds to make sure that the ventricles contract. So the signal will then travel through this AV bundle, which will slow down your signal, and then it'll go to the left and right bundle branches which then speeds up the signal. It'll go to these things called Purkinje fibers, which I drew one here, but basically they're little like fibers at the very end where they can kind of reach every part of the myocardium or the muscle. And this is just all to sync the heart together so that when the ventricles are ready to contract, the ventricles contract together in sequence. And the contraction always starts at the apex of the heart. So it actually contracts at the bottom, and then the sides of the ventricles will then contract a little bit after that. And that's just to make sure everything's synced up and you send the blood properly, without having like one contract sooner than the other, vice versa. We were talking about the pacemaker yesterday for our cadaver patient. The pacemaker, but for the most part, replaces the signal of the SA node. So most likely his SA node failed, or had some irregularities where the signal was not being sent properly. And like I said, the heart is autorhythmic, so it's not gonna if the signal is not working right, then let's say the atrias are not contracting at the same time. Then they're not going to contract the same time every time your heart beats. So you're going to have very differing volumes of blood being pushed into the ventricles and then being sent out the body and then, getting to your organs and your cells. And it just doesn't work that way. Your tissues aren't going to get the perfusion that they need because they're not getting the blood they need. Um, and then it's just not a good way for again, kind of just to get perfusion going. We've mentioned perfusion a couple times. So the pacemaker basically is what sends the heart the correct electrical signal to be doing the contractions and relaxations of the atria and the ventricles at the same time. But again, that's just a very quick summary of the electrical signal that is going to be covered, I believe, tomorrow or on Thursday for the lecture. But hopefully this is a good like an intro to that electrical loop. Okay, and that's all I had. Like I said, I was trying to be very quick. We've just started, so I didn't want to cover too many topics. For this one, my keyword will be Punchinki fibers. So just please message me in Canvas saying that you saw this focus session. Give me the keyword, and then I will mark you down for attendance if you did not attend in person. Other than that, that's really all I had. I will see you all next week. Reach out if you have any questions. All right, bye.